The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
We can hop into Q&A. First question here, this person says, I'm 80 years old. Am I barking up a dead tree in terms of treating my erectile dysfunction?
Every 80-year-old's different. If you're an active 80-year-old with a partner or a significant other or something like that, and you want to engage in sexual activity, absolutely not. The injections are pretty low risk, easily obtainable, and certainly a place to start. I mean, I don't know what you have tried in the past, what has and hasn't worked. There will be something that works for you. Depends on how far you want to go. And if you're a healthy 80-year-old, I think all options are on the table. So there's no age limit on it. I have patients of all ages seeing me for various therapies, and that's not really a criteria we use, that number. It's really about your desire, how healthy you are. Even if you're not, let's say, a candidate for a surgical intervention, there's going to be something else like an injection that works for you, and that's pretty low risk.
Certainly. Alrighty. Next question here. Is there any erectile dysfunction treatment that would be off the table, so to speak, for someone with diabetes?
Bad results for shockwave therapy in diabetes patients. That's been researched. I would say that I don't recommend external shockwave therapy to any of my diabetes patients because it's expensive and it's usually cash pay and the results aren't great. But every therapy is on the table.
Alrighty, good to hear. Let's see. This person says, injection therapy is great for me. It would be also useful to have a longer penis. Is there anything that can help in that way? I think he's talking implant-wise.
As far as the anatomical confines of what you have, kind of what you have. Even with the penile implant surgery, I always tell patients we can't make anyone longer. If you try to put an implant that's bigger than what the natural size accommodates, you're just going to cause a patient pain, and they're not going to be happy. And that's been done in the past. The philosophy on that has changed to, they used to try to oversize patients to see if they would get longer, and that really didn't happen. There is one penile implant called the LGX, length and girth enhancement, that over time can add on some length. But outside of that, there are no therapies which I would recommend as medically studied that give you more length. There's probably a lot of places that claim that exists, and I would be really wary of them.
Question that we just got in the chat. This person wants to know, what are your thoughts on Erexon, the gel that you rub on for an erection?
I don't know. I haven't had any patients try it. I tried to look into the active ingredients of it, and it didn't seem like it was really anything medical grade. I don't know what they're charging for or what the prices are at your Walgreens or anything like that. I mean, see what you think. I bet if it's like $20 and relatively affordable and you come in with low expectations, I mean, give it a try, but I don't know that there's anything to it.
Next question here. Can oral ED meds cause delayed ejaculation?
Maybe very slightly. There's some people that I know that have used some of those meds to try to slightly prolong ejaculation in some patients, but typically they don't. I mean, 95% of the time they don't.
Perfect. Next question here. PDE5 related as well. This person says they're on a 5 milligram Cialis. When taking the injection in combination, would you still take the Cialis?
That's a hard no recommendation on my end, and I tell all my patients not to do that. I think you're really increasing your potential risk of a priapism with that approach. Of course, it depends on really the dose But as a blanket statement, I tell people not to mix those two.
Moving along to some more injection questions here. This person wants to know if there's any difference in effectiveness between the trimix and bimix.
Technically, trimix is adding in a compound alprostadil, which is a known vasodilator, and yeah, it's more effective. I think the more those medications are working on different pathways, and I would say yes, trimix is more effective. I mostly prescribe trimix. But for maybe a guy just starting out on injections, I mean, you don't need to go to something very strong right away. So every one of those tiers of medication has its role, is what I would say. And it's really about finding, what gets you to a satisfactory, good length of time erection.
So I've seen a lot of questions about what is the maximum dosage or the maximum amount they can inject in one day. So I think just generally speaking, how do you establish those guidelines?
I usually tell patients that if you're using one, I wouldn't necessarily tell you to do multiple and separate sessions of injections in one day. I think it's good to give your body a break because these are powerful medications. You're kind of overriding natural systems to produce that erection. I tell my patients that if you're in the 40 to 50 units range, which is also 0.4 to 0.5 mLs, I mean, it's probably just time to bump up the concentration of the medication you're on. That's a lot of liquid. You don't need to be using that much liquid of any of these, and if you are, then it's wise to think about a formulation change.
Moving right along to another injection question. This one is about the needles. This person wants to know, what is the optimal insulin needle size and diameter?
These are the ones that I give all my patients. It's about a half a cc, 29 gauge, or half an inch, 29 gauge needle. So if you know anything about gauges, that's sort of unit of measurements that's used for needles. The higher the gauge, the skinnier or thinner the needle. And you really don't need more than half an inch.
Let's see, moving right along to some more injection questions. This person here says, I'm noticing my penis is starting to curve downward after using trimix. Is there a serious problem I should address?
I think that I would definitely get that checked out with the physician, with the urologist. There is some possible side effects of trimix, including fibrosis of tissue and some curvature that can develop. Guys that are in the age range of when they're using injectables are also kind of in the age range of where Peyronie's disease starts to happen also. So I can't definitively say that they're related, but it could be. And if you notice things worsening with further use, then I'd pause further use until speaking with a men's health specialist.
Alrighty, perfect. So we're going to continue right along with some more injection questions here. So this person wants to know, does trimix or quadmix react adversely with a pacemaker or a Watchman and someone that may be on Plavix blood thinner?
Pacemaker or Watchman, never heard of that. I mean, this is just a medication that's staying pretty local to the penis. Plavix, you can certainly get a little bit more bruising when using injection therapy compared to someone who's not on Plavix. So your chance of hematoma or bruising is higher. It's still not a contraindication.
Next question. This person says, with the understanding my doctor prescribed trimix that is not expired, why would it sometimes work and others not?
There's some variability to it. I can't explain to you exactly what the context of that variability is. Is it related to how aroused you are in that moment? Is it something else in terms of how that drug is delivered? I think sometimes it's just variable, even if those factors are controlled for. So that's not an uncommon story. It's hard to control and make every situation the same, but I wish I had a real answer for you.
That answer is great enough. Alrighty. We have another injection therapy question here, which is actually pretty good. I don't see this one too often. This person wants to know, with ICI, does the injection site open up infection to your partner?
Not that I've heard of. Not that I don't think that anyone's found that with ICI. It's such a small poke hole.
Yeah.
You sterilize the area with alcohol swab. And I've never had a patient have that. I don't think it's even been studied because it's not something that happens.
Let's see. Next question here. This person wants to know if injection therapy success will diminish over time with repeated usage.
I tell my patients, yeah, it will. And the rate of that process is a little bit different for everyone. And I don't know what the key variable is. I've had some guys that have been using injection therapy for a decade. Some guys that after 5 or 6 years say it's kind of lost its effect. It does have some effect on the penile tissues, and if there is fibrosis, I mean, that will change the response you have to it.
We have one more. This person, we actually had a couple similar questions, but people that have tried shockwave, PDE5s, injection therapy, maybe VEDs mixed in there as well, and they're looking for suggestions what the next step may be that might not be the implant necessarily. So I saw one that said, what is the next step without the implant? And there was one that asked just any suggestions in general. So
if you've gone through all of the things that were just listed, I think in my mind, that's really the next step is the implant. I don't think there's a next step. I think those are kind of all the treatment options that are on the board today that are studied. You might find a lot of things about stem cells or platelet-rich plasma, but if ICI or things like that are not working for you, certainly getting a platelet-rich plasma injection is going to be a waste of your money. So the next step for me is an implant.
Moving into the implant questions, this person wants to know how long, I think we covered this in the chat as a review though, how long do the implants generally last, and what are the options for the patient if the implant were to no longer suit them?
Depending on what study you look at, I mean, 2/3 to like 80% are working at 10 years. Part of it, like I mentioned, depends on how much you use it. If there's a guy that's using it once every month or once every 2 months, I mean, it may last 15, 20 years. If there's a guy that's using it 6 days a week, maybe that timeline is going to be 7 years. Like any, implants can be replaced without too much issue. Really, it's a similar surgery in terms of the incision that's used and things like that, and the components of the implant are replaced. The space that the implant occupied is still there, so it's actually not that challenging just to put a new device back into a space that already exists. It does carry a little bit higher of an infection risk.
I guess for the initial implant process, what is the average recovery time for a patient who would receive an IPP?
I mean, it's outpatient surgery for the most part. I send all my patients home. Around 2 weeks, I'll see them back in clinic. 2 to 3 weeks, we'll begin to do some teaching. Teaching mainly involves just getting familiar with the pump, its configuration, practicing inflation and deflation. And anywhere from the 4 to 6 week mark, I'll release them. So long as things are going fine, I mean, I'll release them to use the implant. So as far as the recovery goes, the first couple of days are definitely tough just because it's a sensitive area and there's going to be swelling there. But after that first week, it's not that challenging.
Certainly. And I guess how quickly after an implant may one get back to exercising as well as sexual activity?
That depends a little bit on the technique that's used, but sexual activity, 4 to 6 weeks. Light exercise. I mean, at 2 weeks, I tell my patients they can start engaging in light exercise. I do keep them on a lifting restriction of greater than 10 pounds for about 4 weeks, or as just a precaution. But then at 4 weeks, I just tell them you can go do whatever you want.
Alrighty, next question here. This person wants to know, will an implant help fix a slight Peyronie's curvature?
Absolutely. That's one of the indications for guys that have both Peyronie's and ED. Implants correct curvature in and of themselves to some degree, especially if it's very slight. Placement of the implant itself can sometimes just correct that curvature on its own. Intraoperatively, if it's very slight, then over time, just repeated inflation of the implant can help correct that curvature. And there are times that we do some maneuvers intraoperatively to correct the curvature there. So yeah, they definitely are used for that purpose too. The curvature is severe, you're going to need an adjunctive procedure.
We'll be mixing in some prostate questions in here as well. So this person asked, what is the typical time one should wait before considering an implant post-prostatectomy?
9 months or so. I think almost a year is the right answer. You can, and it depends if you're making progress. You know, if over the course of 7 or 8 months from your surgery and nothing has changed, I don't know that in that next couple months you're going to make big leaps and bounds. So I think, you know, classically the teaching has been a year. Probably shrink that down to 9 or 10 months. And if you don't want to wait, like it's not mandatory. Even if you're 6 months out and you're okay, I know I want this, you can go for it.
Next question here, saw this one quite a few times. Is the sexual sensation after receiving a penile implant the same as having or not having one?
I mean, the implant is mainly in the shaft of your penis, right? It goes into the head a little bit. It's not going to explicitly get the head of your penis hard, but all the sensory nerves and things like that in the head of your penis stay unchanged. So nothing should change about your sensation at the head of the penis, but of course we get more sensory feedback and satisfaction when the penis is in the expanded state. So hopefully that answers your question, that sensation at the head of the penis remains the same.
Alrighty. Next question here. This person says, after prostate removal several years ago, they've tried pills, injections, and pumps, I believe VEDs, with no success. And they're wondering if there's any hope for ED treatment.
I think you know the answer. I think you know the answer to that question. There's always hope. It depends on how far you're willing to go. Injection therapy has not worked, and you have done it in a calculated way, then the penile implant will.
Let's see. I've seen this question a couple times about, excuse me if I'm mispronouncing it, L-arginine. I believe that may be a supplement or a natural ingredient, but this person's asking, can you use this after having radiation treatment on your prostate? And I think they're referring to using it for ED treatment. Not sure.
Sure, you can use it. L-arginine, I believe, is a precursor to nitric oxide production, and you can use it. Radiation will continue to damage tissue over time. So if you look at things like 5 or 6 years out, guys that have had a prostatectomy or external beam radiation, they tend to have, at that timeline, some similar erectile function. But sure, you can use it. It may help a little bit, but radiation will continue to damage tissue over time.
Next question here about implants will be, this is from our previously submitted questions. This person wanted to know how to best select a doctor to perform the surgery in my area.
That's I would just go find someone that does it regularly, and who does it regularly. People that are fellowship trained in penile implant surgery. edcare.com is going to have a physician finder for you of people that do it regularly. There's probably some people out there that don't do them often that still do a good job, but the general theme of any surgery in this profession is that the guys who do more often do a better job. Now, that's not always true. You want to find someone that, if you're having problems, is going to take you seriously and you've built a good relationship with, and is not just going to treat you as a number. So it's harder for me to give you guidance on finding a doctor that you build a good rapport with or trust. But certainly finding someone that does higher volume stuff is going to be more beneficial.
Alrighty, we're going to have time for a couple more questions here. Next question, this person says they have a venous leak and they're wondering if this can be taken care of with a surgery at the same time as an implant, I guess.
If you have an implant in, there's no reason that you need any sort of venous leak procedure. Not that there's any venous leak procedures that have supporting data on them. It got taken out of our guidelines even before I began my training. So for some time, it has been agreed upon that surgeries or procedures for venous leak don't show durable results. Having an implant in place eliminates that concern completely. And in fact, an implant's one of the best interventions for guys with venous leak.
And here's our final question. I think this is a pretty good question to end off on. It is rather general, but on topic for sure. So how do you determine the actual source of erectile dysfunction, if possible?
I mean, thorough medical history and evaluation, I think there's always a feel that you have for a patient. If they have uncontrolled diabetes, they're probably going to have a collection of vascular issues as well. So that's things that I check in all my patients. I make sure I talk to them pretty thoroughly about what their medical history is, what meds they're on, if they have diabetes, what their hemoglobin A1Cs are, if they have vascular disease, where else is it present. You can try to tease it down that way. And that will, as you guys saw on the chart, I mean, those are the majority of the explanations. There's some more objective assessments that can be done, like penile Doppler ultrasounds for cases that are more nuanced. And then a lot of it is, you may not find the answer. And all you can ask your patients to do is live their healthiest lives and provide potential solutions.
If you'd like to learn more about erectile dysfunction treatments, you do have a few options. There are more resources in the Resource Center on menmd.com. You can visit this page to view instructional videos, guides, expert articles, and more. If your question wasn't answered and you'd like to follow up, you may call MenMD at 857-233-5837 or log in to the MenMD portal to schedule an appointment with a personal health assistant. If you'd like to compare any of the treatment options we covered on tonight's event, you can do this by going to menmd.com and navigating to the ED condition page, scrolling down to the treatment section, and selecting up to 3 of these ED treatment options to compare at once. And finally, you can learn more about penile implants and insurance coverage by visiting edcure.com.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.